It's wonderful to see everyone at our 7th roundtable on cost effectiveness, evidence in value for money and funding models. I'm Alex Coulter, Director of the National Centre for Creative Health, and a big welcome to you all. We are in Zoom webinar mode, so we can't see our audience, but we have had over 100 people signing up for this event. And so I think audience will be coming in over the next few minutes, and we also will be recording it and sending it to everyone who signed up. Please say who you are in the chat and interact with each other in the chat. When it comes to Q&A, could you use the Q&A box, which you should be able to see at the bottom of your screen, because that makes it much easier for our chair to keep track of questions. And if you would like to ask your questions to a specific speaker, please do state that, so that makes it easier again. If you have any technical challenges or concerns, do try putting them in the chat. Alexis, our General Manager, is here to support people. The National Centre for Creative Health and the All-Party Parliamentary Group on Arts, Health and Wellbeing's Creative Review aims to highlight the potential for creative health to help tackle pressing issues in health and social care, and more widely, including health inequalities and the additional challenges we face as we recover from COVID-19. We have a panel of commissioners with a wide breadth of expertise, and they will help us translate the findings from the review into recommendations for policymakers to encourage and inform the development of a cross-governmental creative health strategy. Very pleased to say that Professor Helen Chatterjee is going to chair today's event. Helen is Professor of Human and Ecological Health at University College London. She's a trustee of the National Centre for Creative Health and is Programme Director for Health Inequalities at the Arts and Humanities Research Council. She's leading on the Mobilising Community Assets to Tackle Health Inequalities programme, in which NCCH is a partner. Her research includes biodiversity conservation and evidencing the impact of natural and cultural participation on health. Her interdisciplinary research has won a range of awards, including the 2018 AHRC Wellcome Health Humanities Medal and Leadership Award, and she received an MBE in 2015 for services to higher education and culture. Over to you, Helen.
Thank you, Alex. Thanks for that lovely introduction, and a pleasure to be here today introducing a whole series of fantastic speakers that we've got lined up for you in today's session. So a little bit of background about this webinar. This is actually the 4th in a series of different roundtables and workshops that we've run around this topic of cost and value that we've worked on in collaboration with the National Centre for Creative Health, the National Academy for Social Prescribing, and as Alex mentioned, the Mobilising Community Assets to Tackle Health Inequalities grants programme, which is led by the UK Research and Innovation Organisation. And the key themes that we've been coming up with across those workshops, and several of our speakers today have been participating in those workshops over the past few months, is that there's a real interest, of course, in those financial and economic considerations for creative health, social prescribing, and other community-based approaches to health. And it's really important that we can explain and justify the associated costs. But we know that that's really, really challenging, particularly in terms of what sorts of methods, what we're actually measuring. Are we measuring cost? Are we measuring value? What aspects of economic associations are we looking at? And there is no real agreement about that. So we know that this is an area that needs considerably more work. And these sorts of roundtables have been really, really helpful in bringing together different ideas, perspectives, methods, approaches, with what we hope will be some convergence on some ideas about the next step. So a huge thank you to all of our speakers today and in our previous workshops. So we've got some speakers lined up in part 2 of the roundtable who are experts in this area, and they're going to share some of their expertise in that area around kind of methods and what we mean about how best to assess cost and value in relation to this topic of creative health. But we also need to think about sustainable funding and commissioning models for the sector in order that creative health can be fully embedded into systems. So in part 1 of this roundtable, we're going to hear from a whole series of experts who've got different ideas and different perspectives and different experience of funding from the sector. And we're going to hear from, for example, a systems perspective on commissioning creative health, as well as models of collaboration and funding and commissioning that could help creative health to thrive. So we're really looking forward to hearing from our brilliant range of speakers, and a huge thank you for joining us. To start off our session today, I'm really pleased to introduce our lovely colleague Victoria Hume, is Director of the Culture, Health and Wellbeing Alliance, who just do really fantastic work across the whole spectrum of creative health. And Victoria is going to start by sharing the results from their annual National Creative Health Survey and some of the other brilliant work that they're doing to support the sector. So thank you to all of our speakers, and over to you, Victoria, for our first presentation.
Thanks, Helen. It's lovely to be here. I am just going to share my screen. There we go. Hopefully you can all see that now. So, as Helen said, I work with the Culture, Health and Wellbeing Alliance. For those of you that don't know us, we are the national free-to-join membership organisation for creative health. We have about 6,000 members around the country, and we're funded by Arts Council England to do that work. So my job today is to give a bit of context for the meeting in terms of what's actually happening in the sector as far as we understand it. I'm going to share a few very early results from this creative health survey. We've only just closed the survey, so bear in mind that these are quite draft figures. This was a joint project between CHWA and our fellow networks, Arts, Culture, Health and Wellbeing Scotland, Arts Care in Northern Ireland, and the Wales Arts, Health and Wellbeing Network. We will have some more developed results over the next few weeks and months, so you can keep up with those on the CHWA website. Another caveat, we estimate that based on our memberships that there are at least 10,000 people working in creative health, probably many more in the UK. And we've had just over 200 responses in this survey. So clearly it's only a snapshot, but the responses do represent a broad range of practice geographically and in terms of the sizes and types of organisations, as well as about a third of the responses coming from freelancers. And at present, this is really the only dedicated space we've got to learn about how money is moving around in the creative health sector. So to start with freelancers. The freelance workforce, as many of you know, is really the engine of this sector, but it's also where the precarity really bites. Of the 60 respondents who told us about their finances, 7 earned under £1,000 last year, 3 earned nothing. The remaining 50 earned an average of £11,500. On average, this was just over half of their total income, but for those for whom it was 100% of their income, earnings were averaging £15,000 a year. Looking then at the organisations who responded, this might be museums, arts organisations, heritage organisations, libraries. 3 of those spent under £1,000, 3 spent nothing. The remaining spent an average of £151,000 in the last year on creative health, and this represented about 67% of their total turnover on average. So this shows you roughly where the money was coming from for all of these people. You can see quite clearly at the moment the biggest funders are the UK arts councils. And then if you add in the lottery distributors who are a bit further down this slide, you get a sense of that the lottery is funding quite a hefty proportion of this work at the moment. This does reflect recent shifts in strategy in these organisations, and I hope is the beginning of more investment. Not surprisingly, after that, we've got the independent trusts and foundations. For a long time, these have been keeping the sector going through short-term grant making, but they're much less likely to provide core funding, for example. After that, you can see local authorities and the NHS spending roughly the same in this group. And it's perhaps worth noting how little is coming in from donations and things like membership fees. I would infer from that this is a sector that is neither wealthy nor particularly in proximity to wealth, if you like, and perhaps that reflects the relationship between wealth and health that we understand through work on the social determinants. So let's have a quick look at how this separates across freelancers and organisations. This is the average per respondent. So the freelancers are in blue at the bottom. You can really see from this how little is actually coming to the freelancers, except for the slight bump here, which is commissions from other arts organisations. So not surprisingly, this is where freelancers are making quite a lot of their money. Given that these arts organisations are themselves underfunded, this puts freelancers in a state of double precarity, if you like. So I didn't get time to break down the funding, all of the different funding types, but I thought I'd break this down across local authorities and the NHS for the home nation, so the statutory bit, if you like, of the funding. If you look at local authorities and councils, there is some sort of parity across the home nations. This is the average per respondent. But if you look at the NHS, the picture is a bit different. The total spend suggests something quite equal between England and Northern Ireland, but we actually didn't have a huge number of responses from Northern Ireland. When you break it down to the average per respondent, it looks quite different. Looking specifically at England, we would guesstimate that a third to half of our members are probably working in direct partnership with the NHS, so a substantial chunk of creative health. But only 7% of survey respondents got any money at all from the NHS in England last year. The total across the year was £465,000, and in fact, most of this went to just 2 organisations. So very little there from statutory sources, or at least from the NHS in England. I want to caveat that, just going back to that NHS point by saying, again, this is 200 responses, it's just a snapshot. The other thing to mention in particular is that our colleagues in Wales are a bit unfairly represented here. We know that the MOU in Wales between the NHS Confederation and the Arts Council has resulted in significant joint investment into capacity building posts across all the Welsh health boards. And obviously that hasn't really come through in the survey. And it's really important to point out that this joint investment in Wales has been shown clearly to have improved health and wellbeing in NHS patients, in staff, in the wider population, in a report at the end of last year. So we asked people what would help them most in their work. At the moment, this was an open question, and as usual, funding was very much the biggest chunk here. About 40% of people saying that that was their biggest concern. This is something we've seen in every survey we've ever done. In fact, every question we ever asked the sector about what you need is always funding. But what is a bit new, I'm beginning to notice, is that there's much more description of long-term and sustainable funding being the particular issue, and more direct calls for support from statutory sources from places like public health and the NHS. And that to me suggests a bit more confidence in the sector, and I think we're beginning to see some response to that as well. If we break this down a little bit further, this was a question about what's getting funded within the amounts that people are getting. So you can see here that the delivery of the work is largely covered, but where people are struggling a bit more is around core costs, salaries, other overheads, and particularly around training. And you can see here there's very little going into support wellbeing of practitioners. This means that what we end up with is a bottleneck with practitioners, and that those of us in the sector know this well. People, often with lived experience, go into this work with massive passion and enthusiasm because they know how transformative it is. Then they get stuck without the adequate wellbeing support, without the training. They're either burning out or running into kind of career cul-de-sacs, and that denies us all the influence of all that vital experience in more strategic and leadership spaces. I wanted to just share a few quotes. I won't read these. I'm sure we can make these slides available afterwards if you're interested. But I did want to draw attention to this question of transparency and the will to build relationships between investors and the sector. And on that note, I actually wanted to end on a note of optimism. And that's about something that happened during lockdown that has the potential to affect really positive change, I think. What we saw, and this is from a report we produced in April 2021, was that funding, which is so often described as a barrier, suddenly became an enabler. And this happened because of trust. Those providing creative health work and those investing in it in different ways, not just financially, but in terms of partnership, time, support, were forced to trust each other because there just wasn't time to do anything else. And it was really obvious during lockdowns that this was an offer of help that couldn't be ignored. Arguably, people felt more able to tolerate risk and to support innovation. In funding terms, reporting requirements eased. It was not atypical to hear people say things like, you know what you're doing, we trust you to use our investment wisely. We are now, if anything, in a greater, if more dispersed crisis in health and care. So I want to make the case here for trust, for trusting the evolving body of evidence that already exists and investing properly in the expertise that's already in the sector. And that means the sustained core and infrastructural funding that Helen was describing to build a workforce that is able to meet the new demand and help turn that expertise into leadership.
Thank you very much, Victoria. That's such a brilliant way to end, I think, in terms of thinking about that's really what we've got to move towards, is how we can use evidence to think about those more sustained financial relationships. So somebody who can perhaps provide some insights on that is our wonderful colleague and supporter, Helen Rule. Helen is Deputy CEO and Director of Strategy and Transformation at Gloucestershire Integrated Care Board. And she is going to provide that integrated care board perspective that's so important when it comes to funding and commissioning creative health. So a huge thank you to you, Helen, and over to you.
Thank you so much for that intro. So we're going to first of all see whether we can get the tech to work. That's always the critical thing, isn't it? Can you see my screen?
We can, that's looking good.
Hooray, success. Now, I think you want me to talk for about 20 minutes, is that right? Because I don't want to overdo.
If you could try and squeeze it into 15, that would be great.
I can do 15. I just need having expectations clear at the beginning is good, isn't it? So that I don't go on too long. Okay, so thank you so much for inviting me to share this presentation today. So I'm going to try, and I was just thinking actually as you were talking that actually because we don't have all the visibility of everybody on the call, maybe I haven't put this in my presentation, but it might be just useful for me to just say briefly what an integrated care board is and kind of what our responsibilities are. So I'll just take a minute to do that. So the integrated care board is a new way of us working in health, in fact health and social care. So we as an organisation, we cover Gloucestershire. We receive, effectively the simplest way of putting it is we receive all the resources to commission services on behalf of the Gloucestershire population. And we aim to do that in an integrated way, working across health and social care. And to give people a feel, that's over £1 billion of public money that we spend commissioning health for the population of our county. And we work really closely with our local authority partners to think across health and social care. So we work with the Hospitals Trust, with the GPs, etc., etc. So we have that coordinating role, and we run a number of what we would call sort of care programmes, thinking about how we can improve health and well-being, improve health outcomes, etc., on behalf of our population. So the first slide is kind of diving straight into a bit of detail in terms of one of our programmes, but the programme that I think is probably of most relevance. So we have a programme we call Enabling, in fact it's sort of doing this thing where I can't really see the top of my slides, but anyway, I believe that says Enabling Active Communities across the top, so hopefully you can all see that okay. So, and this is a bit of a sort of NHSy diagram, but I'm going to just talk around it because I think it's just useful to sort of set the scene. So we talk about kind of health and well-being, and what do we mean by that? It's quite a global term, and of course it encompasses a wide range of factors, some of which are clearly the preserve of the NHS as a service provider, some of which are about care provision, and many of which sit far outside the purview of the NHS and social care delivery organisations. And I really like this graph, the pie chart on the left, which I believe originated from the WHO, and I'm sure many of you will be familiar with it. But if you look at the things that contribute to an individual's health and well-being, healthcare makes quite a small part of that. So it's estimated around about 20%. Health behaviours, so that's us all, you know, doing the right thing when it comes to exercising, etc., not smoking, drinking, excess, all those sorts of things, come in at approximately 30%. So that's only getting up to about half of the contributors to an individual's health and well-being. And the other half of that is about the environment, the socio-economic factors that the individual is operating within. And key areas such as income, debt, employment, education, housing, the natural and built environment, these are all things that are significant factors in an individual's health. We then think about the psychosocial factors, this sort of self-esteem, social network, social support. We're moving more into the purview of health, particularly public health around the health behaviours. So we have a direct intervention role in smoking, diet, and alcohol. And then obviously the physiological impacts are where we're working, particularly as the NHS, around high blood pressure, high cholesterol, etc. But we have a role to play in every part of these domains. So that for the NHS will be different depending on which domain we're talking about. We're either directly responsible, pale blue, we're a key partner and delivering in part around the sort of medium blue. And in these darker blue areas, yes, we have a role, but probably as a partner, an influencer, a voice in the room. And we describe that role as being an anchor institution. We have that responsibility to our population, to our community, and we need to use our influence, our skills, and to drive projects and programs in that affect that wider health and well-being. So that's how we think about our program. And social commissioning, cultural commissioning, social prescribing was what I was about to say, but cultural commissioning as a subset of our social prescribing spans most of the right-hand side, actually. It is about the physiological impacts, it is about health behaviours, it is about psychosocial factors, and we do touch into those wider determinants of health as well. So people who've heard me speak before, and I won't spend ages on this, will probably recognise this diagram. I will have used it before, but we talk about a continuum of intervention to meet a continuum of need. So in that kind of universal health and well-being, the sort of bottom left of my previous diagram, then we're talking about, we're not professionally intervening from a health perspective, but there are things that we might support, encourage around volunteering, things like neighbours collecting food and prescriptions, work we did in COVID to support some of that, neighbourhood gardening, time banks, these sorts of things. The next in our step is about a non-medical intervention for non-medical needs. So these are people we know about in our population, and that's where we might be linking up with social prescribing, community wellbeing, starting to act on some of those lifestyle factors around things like walking for health, arts groups, lunch clubs, etc. And we might network people within our services for those non-medical needs. So people can have medical needs and non-medical needs alongside each other, and we can think about how we can support people to access some of those non-medical interventions. And actually our social prescribing offer, the most often talked about factors tend to be around debt, particularly lately, around anxiety, economic issues, and not necessarily primarily about health, typical health issues. And then the top of our kind of steps, and where we particularly have focused our cultural commissioning, is around non-medical interventions, but directly for a medical need. So that's where we're taking a clinical need and we're adding a non-clinical intervention to improve the outcomes for that individual. So those are a couple of the examples I'm going to touch on briefly. So thinking about that top step where we have a diagnosis and we are adding in a non-medical intervention for someone's medical need or clinical need, I've got a couple of examples of that. So these are children, this is a children and young people intervention. And we have focused on some children here in our mental health services. And we are focusing through an arts prescription on these particular areas. So it's a biomedical point about physical well-being, compliance with medication, psychological, emotional, it's about mental well-being, confidence, and social, improving that social connection and reducing social isolation. Now, the caveat with my data sets is these data sets are always small. So this one, and I expect people will ask me, so I just checked the numbers, is we've had about 36 children and young people so far through this, and we have goal-based outcomes recorded on about 16. Within that small data set, we've seen a significant improvement in anxiety with being reduced, and post-contact health utilisation. And of particular note, ED admissions, caveating it's a small group, but for pre and post reduced by 80%. So that's a really huge improvement. And here's some stories which are really important to share as well. And what we do with these stories is to build confidence in this non-medical intervention for medical need in our system. We share these stories. We shared them recently with the board of the system board. So we're influencing senior leaders, and we had a patient coming to talk to the group. It was incredibly powerful. And you can see some of the quotes on here, and I don't need to read them out to you, but this is sort of powerful and moving testimony about the importance of these interventions. I should add, and I'm just conscious of time, but we build these through a co-production approach, and parents and families are very involved, as well as the children directly supported. The next one I just wanted to share briefly is Breathe In, Sing Out. It's again a non-medical option for self-management for people living with long-term respiratory conditions. We've been running this for some time now. I really particularly enjoy this one. This is us doing it through Zoom during the pandemic. It's well established now. And we have about, at any given time, we'll be running about 7 face-to-face courses, about 3 online courses actually, a couple of which are specifically targeted towards our long COVID population. And for this group, and again, collecting this data, we use a tool here called Measure Your Concerns and Wellbeing. We've seen significant improvement, but also some of the statistics I'll give you on this group: 72 patients, ED admissions for this group compared to people not receiving this intervention were 100% reduced for 3 months, and 78% reduced when you look at 3 to 6 months. GP contacts down, and we've seen improvement in integrated care team, out of hours, rapid response, all contacts reduced, demonstrating the confidence that people are building in managing their own condition, as well as the physiological impact of singing and the strengthening that brings to their lungs. So here is just again some of the testimony, and I really like the one about a major stressful event did not trigger an asthma attack since they started the singing. It did for that individual in the past, and now it didn't. And it's about the community, and we've really focused these offers on our most deprived communities. So it's not currently available across our whole county. It's focused on our most deprived communities. And you can see the improvement that people have seen in their lung health. So I'm nearly there, but I think what I just wanted to say is, and I'll come on briefly, I haven't talked that much about the funding, but I will finish on that, because firstly, this data set is absolutely critical to us building the case in our community. So we believe we now hold the largest data set probably in the world for creative health interventions. We have several thousand records within this data set, and we have this dashboard. I'm not expecting you to be able to read it all, but it's got all these health utilisation outcome measures, attendances, referrals, the cohort demographics recorded, and every voluntary and community provider that we work with is required to input data into this, and we support them to do that, and we recognise the administrative work taken to do it, and we fund that as part of the contract. You can see that the data set, although it's small around specific projects, is now quite big in terms of what we can measure across the whole. And we look at this contact type as being a key measure of health utilisation and the benefit that we can demonstrate. So what I wanted to conclude is that I think what has been key for me as a senior leader within my system to build commitment to this programme has been about building evidence at scale and over time, that longitudinal data set that we continue to build. The approach we've used from a finance point of view is to pump prime short-term funding to try new approaches, and that has been essential for us to build that confidence But we also recognise the impact of that on the sector, and it can be very difficult if you're asking people to co-produce new approaches with you that they don't have sustained funding for, they need to commit staff time, and they don't know in a year or two whether that will be continuous. But we have worked really closely with the sector to build that resilience. I think having common currency is a challenge in this field. So if you're going to compare to other interventions, you need a currency you can recognise. And that's where we focused on that kind of health utilisation statistics. I should have mentioned probably I'm a health economist by background, so I have particular interest in this. But after some wrangling, we are now moving a number of these schemes into what we would call routine commissioning. So they have proven their place in the care pathway. So Breathe In, Sing Out this year is no longer on short-term funding. It is just an established part of the offer in Gloucestershire. Our arts organisation, Artlift, receives nearly £100,000 now of our resources on a recurrent commissioned basis. Our pain programme, our Living Well with Pain, that is recurrently commissioned. And I'm not saying that hasn't been a challenge, it has been, but the strategic approach at the system level, and if I had longer, I could talk about also the commissioning framework we've built around working with the VCSE, that has also been essential. But I think that the key has been about building that confidence in a sustained way over time, influencing through both the data set, yes, but also the testimonies, the stories, and thinking about where we feed that in, and then building that confidence around their place in the clinical intervention and the health benefits that we can demonstrate. So I'll stop there. I hope that covers what you needed, and happy to take any questions. Thank you.
It absolutely does. Thank you so much, Helen. That was absolutely fantastic. It's so important to have those insights, I think, particularly for providers in understanding that pathway. And you've obviously got such a fantastic model going on in Gloucestershire. We're all very jealous of it. And that pipeline of how you get into that more collaborative approach and that kind of commissioning based on that sustained relationship with pilot funding and that leading into longer term funding, and what the kind of data and evidence looks like. And I know you've been using MICOR, and we're going to be hearing from Marie Polly, who set that up later on in today's session. So a huge thank you to you, Ellen. So next up, a little bit more detail about what some of that practice looks like in Gloucestershire. We're really, really pleased to welcome up two speakers next, who were part of the Gloucestershire Creative Health Consortium. So a huge and warm welcome to Kath Wilkins and Xanthi Wood from ArtShape, who can tell us a little bit more about what that relationship looks like and what kind of work you guys are doing. Over to you, Kath.
Thank you. Hello, everybody. And again, thank you for having us. I've got a very short amount of time, so I'll try and speak clearly but succinctly. I thought it might be good to just talk about the Gloucestershire Creative Health Consortium partners, who we are, what we do, so that people get a flavour for, I guess, the depth and the length of experience for each partner. So the consortium, just so that you're aware, came together in 2020, so it still feels quite early days because there was all sorts of interesting stuff happening during pandemic, but so the partners, there are 5 of us, and all organisations have benefited from trust and investment from NHS Gloucestershire ICB over several years, which helps enormously, of course, in terms of developing our programmes. So the first one is Art Space in Cinderford, who've been engaging people of all ages in the Forest of Dean in arts activities for 35 years. They draw on multiple visual and performing art forms, including circus, and their creative health work focuses on children and young people with long-term conditions alongside partner ArtShape. They also deliver a schools-based creative health service. And ArtShape, who've been working to bring down disabling barriers to arts engagement for 30 years, drawing on multiple art forms, including through an extensive adult education programme, disabled artist development schemes, short breaks for disabled children, exhibitions and events. They are delivering a range of creative health projects, including the partnership work for children and young people with Art Space and the Music Works, and a programme to boost confidence towards employment for people aged 16 plus, for example. Mindsong, who were featured in Helen's presentation as well, a creative health specialist charity that has been benefiting people with dementia through music and song for over 15 years, and who also work with people with lung conditions, long COVID, and aphasia. Artlift, also a creative health specialist charity, started as a project in 2007, delivers arts on prescription services and creative health projects with and for adults living with challenges related to their mental health, chronic pain, and/or cancer. And our artist facilitators draw on multiple visual and performing art forms and genres. Artlift also provides workplace wellbeing sessions, including for NHS teams, consultancy, health setting residencies, and training. And finally, the Music Works are specialists in working with young people and helping them to reach their potential through music. They run studios, workshops, music education in schools, career development schemes, and large-scale events. The Music Works creative health work includes a programme for children and young people with conditions such as diabetes and chronic pain, music therapy on children's wards, and small group sessions to support mental health in schools. So hopefully that gives you a bit of a feel for who we are and what we do, and that we're quite diverse in terms of organisations. Some have multi-stranded programmes of work, of which creative health is one, and others are focused purely on creative health. So, as I said, we came together in 2020 with a view to strengthening cross-organisational working in the local sector. We recognised the length and breadth of experience of the 5 partners and could provide added value in working together in a more aligned and structured way. The partners have all benefited from sustained investment via the NHS over several years, and the NHS have also invested time and funds into the consortium itself for a coordinator and to enable development of a shared data platform, for example. So as well as working on setup, including things like terms of reference and pooling of data, we have worked in partnership on pilot projects, for example, exploring the efficacy of storytelling as a creative health tool. We've agreed a set of shared objectives and a draft headline plan. We've designed a series of focus groups through which to develop more robust and quality approaches, for example, around the referrals process, progression routes for participants, and evaluation. And we were thrilled to receive a Culture, Health and Wellbeing Alliance Collective Power Award last year in recognition of our joint response to the pandemic. So coming on to what we really need to hear about in this roundtable, the advantages of consortium working in terms of added value. So firstly, of course, there's increased cooperative working and sharing of plans, which reduces duplication and potential wasted resource and potential confusion amongst external partners if people are duplicating, for example. It enables us to be more coordinated in our working with external partners, so obviously with the NHS, but also with the University of Gloucestershire. We've been able to share expertise, experience, resources, for example, an artist facilitator handbook, and views on systems, procedures, and approaches, which helps individual organisations develop their team and create efficiencies. Some partners have shared backroom resources. For example, ArtShape and Artlift have shared a referrals processing team and financial management, and joined up on a recruitment campaign to diversify a shared pool of artist facilitators. By working together, I think we've really boosted our confidence and around our shared expertise, which has helped to shape some new joint leadership, volunteer and student placement schemes, as well as some organisations' resources, consultancy and training packages that will benefit other small organisations and sole traders wanting to develop work in creative health. Also, as I touched on before, that it's enabled us to look more transparently at potential progression routes for our participants within and across the partner organisations, but also their wider networks. So, for example, Artlift's mental health participants have gone on to benefit from ArtShape's adult education courses, enabling them to sustain an arts practice and thereby sustain their well-being. So, The other added value, of course, is we're able to access different pots of funding. So the Music Works, for example, can access youth music funding, which others can't. And we all bring existing relationships with local and national trusts, foundations, and public funders. This supports us to sort of scale up where needed. And the longevity and breadth of experience across the partners also provides access to a broader range of volunteers, trustees, donors, and others who can support in kind, many of whom bring invaluable lived experience. And of course, a wider diversity of participants. So, for example, Creative Health Service can be advertised at events reaching over 2,000 people through some of the partners. Finally, individual sustainability of our organisations and our creative health programmes has benefited hugely from the advice and moral support from our consortium peers, especially when we were all under significant stress and workload pressure, all scratching our heads as to know what steps to take next during the pandemic. So that's not fully comprehensive, of course. There are, I'm sure, lots of other benefits I've missed, but hopefully that gives you some kind of understanding of how we're moving forward and how it's helping ourselves as individual organisations and the artists that work for us, as well as the broader sector. So that's all from me. Happy to answer questions later.
Thank you so much, and we're already starting to get some questions in Q&A, and thanks to Xanthi as well. We will start to pick up questions. We might have some time at the end of the first session, but I think we'll definitely have some time at the end of our second session. So thanks to both of you for joining us today. So next we're going to hear from Helen Sharp, and Helen is Director of Ideas Alliance, and they do really, really fantastic, interesting work. And she's going to be sharing some of her experiences of kind of alternative commissioning models and what that might be look like for creative health. So thank you to Helen for joining us, and over to you. And I think you're sharing your screen, aren't you, Helen?
I'm going to try, yes. Thank you so much, and it is an absolute pleasure to be here. I'm going to try and share. Let's see.
Thank you. You're quite quiet, Helen. So if you don't mind holding your microphone near your mouth, that'd be brilliant. Yes, that's lovely.
Okay, right. Right, is that okay?
That's brilliant. Thank you.
Okay. It's really great to be here, actually, because one of the reasons, one of the things that I wanted to talk about is, well, first of all, that we helped to evaluate the creative health programme in Gloucestershire, and things have moved on actually since we evaluated. So it's amazing, Ellen, to see your dashboard and the amount of monitoring and evaluation you're able to do now. But even before that came into place, one of the things that we reflected back to Gloucestershire was the fact that we know that it works. You had enough even then to prove that it works. And actually it was now about taking that confidence forward, and rather than sort of being a little bit tentative about where you go from here, now it's about, right, really sort of making this something much more in a commissioning way, much more formal. And there was stuff that was coming back from some of the providers, which has already been touched on, this idea of sort of annual budgets, you know, not being able to plan, worries about whether you could keep staff and that sort of thing. But also there was the issue of having, you know, a range of different providers, and you're having individual contracts with each of those providers. So that the consortium arrangement is absolutely fantastic. But I'd like to sort of, I guess, take it one step further. And I'm going to briefly touch on some of the things that we're working with other areas on, but also that Gloucestershire is very much leading on. This idea, first of all, for commissioning for outcomes. And what's really interesting about commissioning for outcomes is that quite often we try to commission for outcomes, but we get those outcomes wrong. So we don't necessarily start with the people with lived experience. We quite often follow what the system is telling us. And quite often those outcomes are not actually what matters to the people. And what's going on in Gloucestershire is they're using co-production in order to ensure that whatever it is that they're delivering really matters to the people that they're delivering it to. And that therefore means that the outcomes that they're achieving matter to those people. And what you'll find is that the outcomes that really matter to people are all about well-being. I'm just going to very quickly show you a set of outcomes that we created in Dudley through a storytelling process. And this is the stuff that really matters to people. And when you look at the creative health programme, this is the sort of stuff that the Creative Health Programme is really affecting. And it fits really well with that slide that Ellen showed of all the different sort of determinants for health. I'll come back to that in a minute, but it's then that idea of commissioning for collaboration. Now, within Gloucestershire, they already have a consortium model, which is fantastic. But what you'll find as a commissioner, that often comes from goodwill. And really what you're looking for is within a creative health programme, a mechanism by which you can influence that collaboration. And where one of the recommendations that we put to Gloucestershire was this idea of creating an alliance contract so that each of the providers would be under one contract. So I'll just share another slide with you here. The idea of an alliance contracting isn't new. It's been around for about 10 years, but it's really gaining traction at the moment, because what tends to happen is that as a commissioner, we have individual contracts with each of the different providers. But what that can do is it means that we, as a commissioner, retain that sort of parent-child relationship with providers, so that the providers will come to us in terms of being that diplomat, that negotiator. You know, that provider's not doing what we're expecting. Can you have a word with them? We become the sort of the fixer. And what we also tend to find is it creates this sort of race to the bottom, because ultimately those providers end up having to compete against each other. When you shift over to an alliance contract, those providers are under one contract with the commissioner, but you as the commissioner are always also part of that alliance, which means that as an alliance, you are having to work out together how you're going to do things. You're sharing resources, you're sharing the risk, you're sharing the gains, your performance managed through one contract, so you're not having to do different contract management between each of the different contracts. And ultimately what it does is that you join people together under the same aims and the same principles and the same outcomes. And that creates this amazing force and this amazing ability to be able to try stuff out. So one of the things that we're really interested in terms of any creative health program is that shift towards commissioning towards an alliance contract if possible. The other thing that we're very interested in is this idea for commissioning for co-production, which the Creative Health Programme in Gloucestershire is absolutely running with. And it's that whole idea of rethinking the role of citizens so that they're not just the sort of the recipients of our services, but they actually play a massive part in how we design those services, but also how we deliver those services. And most of the providers under the Creative Health Programme have lived experience themselves, so they're able to share that with other people. And you'll see the quote that came from one of the slides that Ellen put up around this idea of being able to share my experiences with people who are also in the same place is really, really valuable. But also what you'll find is that most people who receive services want to give something back. So in fact, people with lived experience, the people we are serving, are one of our greatest resources. And finally, it's that idea of commissioning for learning. So rather than performance managing according to activity, you're actually performance managing in a way that helps you really iterate everything that you're doing. And that's already coming out again within Gloucestershire. So it's that idea of prototyping, pump priming, testing stuff out, seeing if it works. But I think my final sort of feeling around what's going on in Gloucestershire in particular is we know it works, and you now have that evidence, and it's about really sort of using that to feel the confidence and to really do something that's quite formal now, I think, in terms of your commissioning. And I'm going to end there. I hope that's okay.
Helen, that was so interesting. Thank you so much. I mean, that the alliance model of collaborative commissioning, I think, is absolutely the way forward, isn't it? And thinking about those questions about tackling the wider social determinants of health, that's even more possible when you're bringing in all of that different expertise. You're thinking about different outcomes. So really appreciate that. And anybody who's got any ideas of or examples of alliance commissioning, we'd love to hear more about that. So please do share. Thanks so much for sharing that with us, Helen.
That's a pleasure. And also just to say, there are about 20 different alliances running across the country at the moment, from very large systems-wide alliances to much smaller ones. So if anybody's interested, give me a shout, and I'm happy to put you in contact with them and talk to you more about alliancing.
That would be, we definitely are, as part of our UKRI programme. That's a big piece of work for us, and the work that we're doing obviously through NCCH and NASP. So we'll definitely follow up on that. Thank you, Helen. And last but by no means least, we're going to move to our final speaker in our first session, to the wonderful Tim Joss, who is Chief Exec and founder of ESOP. And Tim is going to introduce ESOP's work, particularly around their Dance to Health programme. So over to you, Tim, and thanks ever so much for joining us today.
Thank you so much, Helen, and lovely to be here. I'm going to share my screen. I'm going to give you a short presentation. Here we go. Can you see that all right?
We can, that's looking good.
Lovely. Okay, so the ESOP board and I, we've reached, I think, a tipping point in terms of health investment in the arts. And this short presentation is just going to explain the journey we've been through and where we've reached. So before setting up ESOP, I was, sorry, it's not going across.
Tim, you might have to, if you hover sort of over the bottom left-hand corner, there might be a little arrow. Sometimes you see.
Oh, that's weird.
Right at the bottom there.
Or otherwise, Tim, click on the screen, click on your screen and then try again.
Ah, progress. Thank you very much. Okay, so before setting up ESOP, I was director of the RAIN Foundation, so one of the charitable foundations, and we funded a lot of arts and health, arts and education, and arts and criminal justice projects. And we reached these three main conclusions. In brief, what this is about is that the work is really powerful. It could be helping solve other sectors' challenges. And the thing that didn't seem to be happening, it needed to scale, because speaking about health, the NHS wants services which can be made available to all. I looked at what the way in which arts organisations were making their case for wider impact. And here are some recent examples. I think they project very strong values. There's a real sense of commitment and energy. But what I did wonder was whether they were actually convincing other sectors. So we call that approach Arts Push. And looking at those quotes from the Creative Health report, where we are is that it suggests that we're not getting that breakthrough, that we've had 50 years of realizing only a small modicum of the arts potential in health. An early practical thing that we did, now this is 10 years ago, was to develop the first evaluation framework for arts and health. And Professor Dame Sally McIntyre helped us. She'd been one of the authors of a Medical Research Council framework for the development and evaluation of complex interventions. And Sally said any arts intervention could be seen as a complex intervention. It could fit into this framework. Those of you who are familiar with health research will know the influential Cochrane evidence library. And I'm going to read this. This is what Archie Cochrane said 50 years ago. I cannot agree with colleagues, however distinguished, intelligent and hardworking, and who obviously believe that they are doing good, should have a blank check to encourage the use of, insert a program, without bothering to measure the benefit and cost of what they're doing. So we wondered about this and came up with an alternative way of approaching the way, how we could get breakthrough for the arts in health. And we call it Health Pull. And there are three key questions we ask ourselves. The first is, what are the NHS requirements of an adoptable innovation? The second is, does Health Pull compromise artistic freedom and integrity? And lastly, the practical question, how does the NHS pull in an innovation? As well as new thinking, we needed an exemplar. Now, Helen has mentioned it, it's Dance to Health. 10 years ago, Age UK were campaigning about older people's falls. Falls cost the NHS £2.3 billion a year, and the NHS's solution is well-evidenced physiotherapy programmes. But we knew from research by Public Health England that these programmes are dull. Older people find them really boring, and not only that, but the completion rates were really, really low. So we saw an opportunity here. So we created Dance to Health. It's the National Falls Prevention Dance Programme. And between 2017 and 2019, we ran a £2.1 million development programme, and it generated these results. So we got participant outcomes that the NHS wants. We were able to show that it was effective and cost effective. And lastly, that it, going back to what I was saying about the importance of scaling and making something a universal service, it was scalable. And therefore we had answers to the first two of those health pool questions. We met the NHS's requirements, and dance artists did not feel compromised. They found delivering Dance to Health artistically rewarding. Dance to Health now is moving from a grant-funded innovation to a social enterprise driven by earned income. Sales have been doubling every year, and we had a most wonderful recent boost. It's just been announced that we've got a £328,000 award from Innovate UK. They had a call called Scaling Healthy Aging, Scaling Social Ventures. So our overall vision is a future when art solutions for society's problems are valued and available for all who need them. We've set up the ESOP Institute. It's there to help the art sector grow its artistic impact, its social impact, and its earned income. And over the time that I've been working on ESOP, we've actually developed 10 missing, if you like, building blocks, things that we needed in order to achieve an arts breakthrough into health. An early one was that evaluation framework which I mentioned, and the latest is called Prescribe Arts. It's a platform which links social prescribing link workers with arts organisations with arts and health programmes. We already have 102 arts organisations on board. So back to this idea of the tipping point. We think that there are four main drivers to achieve breakthrough, and they're all about health pull, or more broadly, society pull. The NHS has been working since 2011 to speed up the adoption of innovations. Research published that year found that it took 17 years on average for the NHS to adopt an innovation. 17 years. Fast forward to today, and NHS innovation adoption is highly developed, brought together by the Accelerating Access Collaborative. It's currently working with 2,804 innovators. Innovate UK is supporting a few arts programmes which deliver well-evidenced, cost-effective, scalable social impact. NASP, of course, are strongly engaged with the arts. And finally, other sectors are now asking us to help solve their challenges through the arts, and they will pay us. A photo to finish. This has been a sense of arrival for us. Dance to Health was one of just 6 innovations featured in a celebration in February called Innovation Transforming the NHS in its 75th year. Panning from the right, you can see, as well as ESOP team members, Mark Whitty, he's the Chief Exec of Accelerating Access Collaborative, members of the Birmingham Bangladesh Women's Association Dance to Health group, and in amongst them is Amanda Pritchard, the Chief Executive of the NHS. And then over to the left and a bit and behind is the wonderful Tony Young, Professor Tony Young, who's been such an ally to us. And Tony is the NHS National Clinical Lead for Innovation. So we've reached a point where I think there really is a chance to achieve a tipping point. I think it's coming. Thank you very much.
Tim, thank you, and many congratulations on those brilliant achievements. Great to hear about the Innovate UK funding, and I think the more that we're seeing different sources of funding, particularly around building that evidence base, and like you say, building different kinds of evidence and understanding what that looks like, the more I think we can see brilliant progress like you've achieved with ESOP. So congratulations. Thank you to all of our speakers. We're sort of running a little bit ahead of, not ahead of time, lacking in time. So I'm going to ask if we can defer our Q&A session until the end of our second speaking session, so that we get time for a little bit of a comfort break. I'm keen that we all stand up, do a little bit of moving around. So what I'm going to suggest is that we have a break now until 10 past 11. It's technically 9 minutes, so apologies, you're going to lose a minute of break time. But we'll then move into our second half of talks, where we're going to hear from some of our experts, researchers who've actually done some of this kind of work to tell us about the sorts of methods, modes of research that they've done. And then we'll move into Q&A. So please do keep posting your questions in Q&A. And a huge thank you to all of our brilliant speakers thus far. It's been absolutely enlightening. Really, really appreciate your insights. So thank you. Already at 10 past, I hope our the rest of our panelists and our audience are with us. Very warm welcome back. And I'm very pleased to move on to our next part of our session for this morning, looking at cost effectiveness and value in creative health. And what we're going to hear from now are some brilliant speakers who've been doing some of this work over a number of years, thinking about different approaches, methods, some of whom have been really influential in thinking about what it means to understand cost and value. And those terms mean very different things, of course, to different people. So we're going to hear from different perspectives today. So first up, we're going to hear from Andy. Dr. Andy Healy is the Senior Health Economist on the Shaper project, and he's from King's College London. And so Andy's been involved in the economic analysis of the Shaper project. He'll tell you more about the Shaper project. Some of you will have heard of scaling up health arts programmes, implementation and effectiveness research, which is based at KCL, King's College London. So Andy, over to you. We're really looking forward to hearing about the sorts of work that you guys have been doing.
Thank you very much, and hello to everybody. I'm just going to share the screen. So I hope you can all see that.
It's coming, it is. Thank you. We can see it.
Yeah, I'm actually not going to say a great deal about Shaper, because we've not finished. We're still in the process of sort of thinking about what we're going to do and how we're going to analyse the data that we're getting from that project. But what I will talk about is some of the methods available for evidencing value for money in this kind of creative health space. So a bit unusually for an economist, I won't be presenting any numbers. I'll just be talking through some of the key sort of tools that are available for looking at the question of value for money. So as you were saying in the introduction there, Helen, I'm an economist, and economists, the approach that economists take to evidencing value for money is through something called economic evaluation, which is essentially a framework for bringing together different sources of evidence, clinical evidence, epidemiological evidence, economic evidence and data to allow the costs and consequences of programs to be quantified and compared. Now, that there are different types of economic evaluation to choose from, and the type of approach that you choose really depends on the perspective that you want to take. So in a sense, that's the question around, value for money to whom, which is an important question in itself. And also, of course, who the evidence is intended for, who the audience is. So the kind of the bread and butter form of economic evaluation undertaken by health economists who evaluate healthcare programs is something called cost effectiveness analysis. And this is the preferred currency for the National Institute for Health and Care Excellence when they make recommendations around the adoption of innovative healthcare programs and technologies. And what's kind of unique about this type of analysis, firstly, is that program benefits are quantified in terms of their impact on health-related quality of life and or impact on life expectancy, if that's relevant. And these impacts tend to be summarised within a metric called the quality adjusted life year, or the QALY, which some of you may or may not have come across. And in terms of the costs, in terms of the cost side of the equation, the emphasis is very much on looking at the resource effects and costs to the NHS and the care system. And the key sort of summary measure in a cost effectiveness analysis that an organisation that NICE would look at is something called the incremental cost effectiveness ratio. So this measures what it costs what a programme costs, in this case like an arts-based activity or a creative health programme, what that would cost to generate a single QALY. And if the incremental cost effectiveness ratio, or the ISA, is less than £20,000 per QALY gained, then NICE would typically suggest that would be evidence that the programme offers value for money. That's a kind of a predetermined threshold that NICE typically use when assessing value in healthcare. Now, if you want to broaden things out and consider things from a multi sort of stakeholder or from a societal perspective, then really the best approach to look at the issue of value is using something called social cost benefit analysis or social return on investment analysis. These are sort of terms that are often used interchangeably, but essentially they mean the same thing. And this is, generally speaking, the go-to method of economic evaluation in government, and is probably more relevant to commissioning decisions where there are sort of multi-agency models of funding. And it's quite a reductionist approach to evaluation, in the sense that the emphasis is really about trying to monetize the main impacts to the key stakeholders in terms of benefits and costs, so that a direct comparison can be made of whether the benefits associated with delivering a programme compensate the costs involved with delivery. And the typical sorts of measures of value that are employed with this sort of approach would be the production of a benefit cost ratio, which sort of measures how much benefit you get per pound or per dollar invested, or through sort of a net present value, which is more relevant, where you've quantified a stream of costs and benefits over a period of time. And if these measures are sort of positive in value, then that would give an indication that the programme of interest is worthwhile providing in these terms. I just thought it would be worth very quickly outlining some of the approaches or candidate approaches that might be used to monetize the benefits to programme participants when you're carrying out a cost benefit analysis or a social return on investment analysis. So if you've been able to, through your evaluation, to be able to quantify the quality adjusted life years gained through a created health programme, there are estimates used in UK government around the value of a QALY, which you could apply to your estimate of the QALY gained. More recently, there's been work around the use of life satisfaction or well-being approaches to measurement of value. So this would typically involve measurement of programme impact along pre-designed scales of well-being or life satisfaction, and then you can infer the monetary value of those gains through pre-existing estimates of the relationship between well-being or life satisfaction increases and household income, for example. So, but of course, it's often not possible or even desirable to monetize all impacts. And an alternative approach is something called cost consequences analysis. And this, like cost benefit analysis and social return on investment analysis, again takes a multi-sectoral, a multi-stakeholder or societal perspective, but the emphasis here is really on just presenting the cost implications alongside the consequences or outcomes of a programme measured in their natural units, and then you sort of allow decision makers to make their own judgment as to whether the costs or as to whether the benefits are worth the costs associated with delivery. And that's kind of I think that is really going to be the approach that we take in the Shaper evaluation that was referred to at the start of the presentation. Just quickly, some final remarks. Economic evaluation is informationally demanding and can be quite complex to carry out. So you need to be prepared to invest some money in it, some resource in it, and you need the expertise to do it as well. I think you need to be prepared for economic evidence to be scrutinised. So it's important that when you're presenting the outputs from an economic analysis of creative health, that you're transparent about the assumptions that you make and the uncertainties around the conclusions that you reach. And finally, I think it's also important to be prepared for some challenging findings. You know, it could be, for example, that the economic evidence suggests that some approaches to improving health through creative or arts-based approaches are better than are more impactful than other types of approach. So, you know, it's important to bear in mind that that the evidence delivered by economic evaluation can throw up challenging findings and issues around prioritisation. So I'm going to finish there. I hope that was useful for everyone.
It really was. Thank you so much, Andy. And that summary of all those different types of approaches and methods is really, really important in understanding what's the difference between a QALY and a Wellbeing. We hope that we can answer some of those questions in the report through the Creative Health Review, and also the report Marie, Polly and I are leading on for NAS, National Academy for Social Prescribing, where we've been working together with NCCH and bringing together lots of people like Andy, other colleagues who are on this call, Kerrin Husk and others, trying to get our heads around what all these different methods and approaches and what's the best way to use them. And without further ado, a person who can address many of those questions is, of course, the brilliant Marie Polly. She's my wonderful co-lead at the International Evidence Collaborative at NASP. She's the founder of Marie Polly Consulting, and she's also, of course, the co-founder of the Social Prescribing Network. So many of you will be familiar with her brilliant work, but she's done a huge amount of work in this space of thinking about how we can best capture and measure what matters most to people. And so she's going to tell us a little bit about how she's been doing that through her different methods that she's developed. So thanks, Marie, and over to you.
Thanks very much, Helen. And today I don't have slides. I'm just going to talk a little bit, and I've got 3 points. So 3 points that fit with what the previous speakers have probably raised, and some thoughts from that kind of overview of all the sectors, you know, from my experience of running the social prescribing network and liaising with just hundreds of different people, and listening to what people say around, you know, value, and also, you know, from our work, as you mentioned, that we're doing for National Academy of Social Prescribing, trying to understand how to support evaluation and untangle this sort of how do we assign value to non-medical interventions and approaches and services. And I know someone put a question, what is non-medical? I suppose for me, it's just something where you're not giving somebody some drugs and they're not in the fixed health framework. So the first point I wanted to talk about was about meaningful outcomes. So we are really just emerging from a long era of health outcomes being prioritised when making a judgment on whether intervention services are successful. And, you know, I think we've heard some fantastic information this morning that shows how we are just emerging out of this world. And 20 years ago, I helped develop Measure Yourself Concerns and Wellbeing tool, or MyCore, that Helen and Ellen have talked about already. And I've spent years pioneering methods of capturing the personalized holistic approaches, you know, and outcomes associated with the personalized holistic approaches to care, including, you know, working in this outcome fields with social prescribing. And I think I can say with certainty, irrespective of why a person is referred into a program, an intervention, or a service, people value outcomes that are much broader than health. And actually, if we went back to that image that Ellen showed right at the beginning, 40% were social determinants of health, 20% were only health specific, and there were other parts to the pie chart there. People value physical and mental health, and that's most often measured and monitored, particularly in social prescribing. But people really value spiritual health. And by that, I mean the purpose and meaning in their life. Really common to talk to a service user who say, I just feel like I've got more purpose, or I go to this intervention and I've got a purpose or a reason to get out of bed on a Thursday because I know I'm going to go to this creative health intervention. The people also value ways of improving and taking control over their well-being. So not their health, but their full well-being. Often people say, I want to support my own well-being, and that comes in many different ways. But people, we know from data we've collected, value support with many practical aspects of life. And those fall into the social determinants of health. That's your finance, your housing, legal, welfare support and justice, practical issues that crop up in life, supporting activities of daily living, all sorts of things. But these outcomes always seem to come below health outcomes when you're reporting. Yet if social determinants of health were dealt with quicker, health would improve faster. And that is really well evidenced by Michael Marmot and many other people about the allostatic load of stress on the body when your determinants of health need supporting. So I don't understand why we're still talking about it and not really actioning, prioritizing social determinants of health, but that's maybe another story. But with MyCore, this tool that asks people, what are your concerns that you want support with? It also asks that follow up, what's been most valuable or important about the service or support they've received? And without fail, people respond to say it's the care, the kindness, the love, the compassion, the support they've received. And they value being with other people who understand their situation. And they value being heard and giving the opportunity to say what their concerns are. And we have global data sets on this now. So, you know, this is just common literally around the world. And this data is absolutely crucial. You know, so if you know the concerns of your service users, you can use it to develop service models that work for people using the services. It sounds like a no-brainer, and it's just so great to see how far the work's come in Gloucestershire. So that's been really great to see this morning. My second point is around methods for establishing value. So as Helen mentioned, we're currently undertaking some work with the National Academy of Social Prescribing, looking at how to support evaluation for small community organisations and resources that are being used, and also understanding more about the economics associated with social prescribing and value quite broadly. And Andy just outlined a range of approaches to determine economic value. And as he said, it can be quite complex and you need to invest time. We have held some roundtables and we've done quite a lot of listening to people again. And some of the emerging findings are that there is really not a shared language amongst all the different sectors around economic value. And there aren't really shared methods that people accept for capturing the broader outcomes or for assigning value to many of the interventions. So whilst Andy outlined what methods there are, we are hearing very clearly that there isn't a lot of joined up thinking between major funders, government departments and policymakers on what constitutes the right evidence. So you could go to Department of Health and Social Care and they would prefer one particular method for determining economic value. DCMS or DEFRA might accept a different one. So that's one issue, but also what is enough evidence? Like, how much evidence do we have to provide before it's enough? And in Gloucestershire, we see that they've moved from the small commissioning into just standard. This is part of the offer now, and again, that's fantastic. So I think it's really crucial as we're now moving to collaborative working and commissioning at place and across sectors, that there is more agreement, or there is any agreement on methods of economic value. And I think that would make it a lot easier then for everybody on the ground to know what they're meant to be doing. That would be accepted as that data goes much higher up to policymakers and government departments. And I think what is much of what is accepted, I think, encompass what is important for an individual as opposed to a clinician or policymaker. So those two things I think are really linked. My final point is about capturing and analysing the data. And most data is captured over 3 to 12 months of a person taking part in an intervention or a service or some creative health support. And again, research that I've done on outcomes in social prescribing shows that actually some outcomes take a bit longer to improve compared to what firstly is being put in place. So you can have, you can support a person with creative health and social prescribing, and you can get some really fast improvements. They might feel their well-being improves, they'll feel more hopeful, they may quite quickly feel less lonely. And that's great. But actually, a person in poverty who can be given immediate food and crisis money might still need weeks or months to get the benefits sorted out, because you've got to review the benefits and then those changes got to be put in place, and those changes always take quite a few weeks. Or their fuel poverty, for instance. You know, again, these things take a bit of working through. So they are almost like the short to medium term outcomes. Then some outcomes may take months to years, but can be significant and life-changing. So an example here would be providing support to improve a person's CV or their English language or skills for work, and supporting a person to get back into employment, something that social prescribing is very good at. And actually, I think that many of the longer term outcomes are not captured, nor is the ripple effect of what happens to a person, say when they benefit from creative health support. You know, so an example would be an adult who becomes more creative and takes up a method of creativity will improve the chances of their child taking up a creative activity as well. And that becomes protective for a child's mental health. And that has massive value because our children's mental health system has all but collapsed at the moment. And that is evidenced. So how do we value that? And how do we bring this all into our broader discussions of value of creative health? So just finishing up, if I boiled that down, I would say that I think we need research that's carried out over 5 to 10 years to capture a much fuller impact of non-medical support such as creative health, and have time for those range of outcomes to mature to then understand what the full economic value is. I think the research needs to include outcomes that are meaningful to a person, as well as policymakers and clinicians. And I think we need more agreement at a high level between government departments, key policymakers and fundants they think is acceptable, and particularly what economic-based evidence is required for them to accept that creative approaches to improving health and well-being do deserve equal recognition in many cases to medical approaches. And I suppose I'll finish by saying I see the role of the NCCH and NASP as playing, you know, playing the convener now to bring these high-level stakeholders together to agree what is relevant and acceptable for establishing economic value and the wider value of creative health. Then everyone else underneath that can get on with just providing that data. So that's me. Thank you.
Brilliant stuff. Thank you so much, Marie. As always, fantastic insights. I'm going to move us swiftly on to our last, but by no means least, speaker today, Dr. Daniel Fujiwara. Lovely to see you again, Daniel. It seems like it's been a long time. Daniel is the CEO of Symmetrica Jacobs, and he also works for LSE in the Department of Psychological and Behavioural Science. And he's really been one of the leading thinkers in terms of social value measurement. And he's done a lot of that work in relation to arts, culture, heritage, in particular working with policymakers. So we really appreciate you joining us today, Daniel, and over to you. I don't know if you're screen sharing. Daniel, you've got some slides. Yeah. Brill.
Let me just do that.
That's looking good. Thank you.
I'm getting to the full. There you go. Does that work?
That does work. Brill. Thank you.
Okay, thank you. And good morning, everyone. So yeah, I'm really excited to talk a little bit about the work that we've done and provide a series of case studies looking at both kind of the valuation element, but also cost effectiveness, as well as methodologies that can be applied generally in the arts, but also, you know, in the creative arts and activity sector as well. And I was going to start with a bit of a description or a breakdown of the different forms and methodologies, but Andy did such a great job. I don't think I need to do that at the moment or anymore. So just kind of recapping on what he said, we have these kind of methods that don't value the outcomes, but look at the kind of the cost of producing an additional outcome. So the QALY was one example that Andy raised there, but there are other types of outcomes that you could look at. You could look at, for example, the cost of getting someone through university. That would be one form of cost effectiveness analysis. And then on the flip side, we have cost benefit analysis, which goes one step further to value those outcomes. And I think what I'd add there is just kind of, I guess, some of the background context around how globally this is developing into a fairly standardized set of recommendations or guidance. So in the UK, we have the HM Treasury Green Book, which really sets out the requirements within government when they're funding or when they're looking to fund a new program or policy. What are the analysis or assessment requirements around that? And cost benefit analysis is really the core of the Green Book, but it does allow for other methodologies in there as well. So CEA, or cost effectiveness analysis, is also one of the methodologies, especially around health, using the quality adjusted life year that is recommended in the Green Book. And if we look further afield, the OECD guidelines, this is just one of them around applications to the environment, but they have a series of others. They all kind of say the same thing, which is, you know, cost benefit analysis seems to be the key methodology to use, where we're valuing outcomes, both benefits and costs wherever we can. And there are a set of standardized methodologies that you can apply within that. As Andy mentioned, there are a few different methods to derive these types of values. And Andy mentioned the Wellbeing valuation approach, which uses life satisfaction. I'll cover one example of that, but I'll also show you some contingent valuation case studies as well within that. So the first case study I'll go through is some work that we did for Arts Council England and the British Museum. This is quite a while ago now. But we had people who were inputting into an app on their smartphone how they felt at different points during the day. and what activity they were doing. And also we were able to geolocate where those individuals were when they were doing that. So we could see, for example, having a picnic, and we could see that that was happening in Hyde Park at 3 p.m. on a Sunday, for example. So taking all of that data, we had about 2.3 million data points over multiple years of this data set. For the Arts Council, we looked at how kind of activities, cultural, heritage and arts related activities impact on people's well-being through the day. And we looked at, in the pink text, or the pink font, we've got a series of kind of arts and culture related activities, including hobbies as well, and crafts, and how they relate to the 5 most other frequent activities in the data set. So things like drinking alcohol, childcare, watching TV, are some of the most frequent other activities in the data set. And these figures that we have here can be interpreted as percentage changes in happiness. So going to a theatre or play, a dance or concert improves your happiness by around 9%, during that period. So that could be a 2-hour period, for example. And what you can see here is that relative to the most frequently conducted activities, arts and culture and creative related activities actually score very highly. Most of them are at the top of the list. And actually there are very few activities, if we broaden this more, there are very few activities that actually performed better than these types of arts and creative related activities. And you can see that this covers both kind of being audience to these types of things, but also participating. So we've got things like singing, performing, and hobbies in there, which covers the participation element as well. In a separate study we did for the DCMS, we actually took that type of data of engagement within arts and creative activities and how that impacts on people's well-being. And rather than looking at happiness, we now looked at life satisfaction. So life satisfaction is a slightly different measure of well-being. It captures more kind of an evaluation of someone's life, whereas happiness is kind of more in the moment moods and feelings. So over the period of a year, we saw, for example, when we looked at different forms of cultural activities and sports activities, that any form of engagement in the arts had a positive effect on people's life satisfaction. So this could be going as an audience member to something, like a theatre or a play, or it could be participating in it. So practicing ballet, drawing and painting, listening to music, or playing music, sorry. And that had a value of around £1,084 per annum per person. And we could get a breakdown of kind of monthly as well. And this was to do it on a fairly frequent basis. So it's not kind of doing it once a year, but it'd be doing it, a number of times per month. And we're able to look at some of the breakdown of that. So, for example, going to music venues often has a value of around £742 per annum per person. So we built with DCMS kind of the start of a data set that looked at the correlation with well-being and what those values would mean, or what the impacts on the well-being would imply in terms of actual values to these individuals. So the DCMS can use this type of data to say that, okay, through this program or investment, we've got 1,000 more people involved in the arts, and the value of that would be 1,000 people times £1,084, for example, per annum. Another extensive area of work that we cover is in visiting arts or cultural institutions. So we've now completed around 100 different studies of this type for DCMS and Arts Council England. This is one example of the Natural History Museum, where we look at people that access or go to a museum or go and participate in a creative activity at a museum. So it could be an object handling session at the British Museum, for example. That's one of the areas we've covered before. And in this particular study, we found that the value per individual of going to the Natural History Museum was £6.65 per visit. So again, museums and institutions that deliver some form of participation in the arts or creative activities can take this type of data and effectively multiply it by the number of visitors, and that gets you an overall value that this institution or that this program is generating. And within the same study, we're able to break down the kind of well-being that people perceive during that visit across different areas of the museum. And we found that the highest levels of happiness were when people were in the paid exhibition / gallery areas, whereas the non-gallery areas didn't have such a high level of well-being. So we've conducted studies like that for the British Museum as well, where they're interested in understanding what forms of participation or what areas of a museum or institution generate the highest levels of well-being and have the largest impacts. The final case study, just to take you through, is some work we did a number of years ago for Age Exchange for their Radical program. So this is an arts reminiscence program for people with early onset dementia. So there's a range of creative and arts related activities there. A lot of it is music based, could be singing, listening to music, but it can also be doing arts, for example, painting and stuff like that. And it just helps those people in these care homes to kind of connect with their history a little bit more, but also with their surroundings and other people in the care home. So in this evaluation, we had data from 12 care homes, 6 had the radical intervention, and we had 6 control homes. So these control homes are basically similar homes, delivering everything else on a fairly similar level, but they just didn't have the intervention going on at the same time. And we looked at 2 types of outcomes, a mood and engagement score, which is on a scale of 0 to 10, which is really just how those patients are feeling at different points during the day, kind of similar to the happiness score. And then a kind of composite index, which is a behavior category code around the types of positive behaviors that were perceived, that the nurses and the staff could see that the patients were engaging with. So that could be, for example, self-care or doing something themselves or feeling more confident. There's a composite score that's built there. And you can see that the data over a 30-week period that we looked at, the control sites were a little bit higher because these programs were going into care homes that were doing worse off, or where the patients were doing worse off initially. So they always start a little bit lower. But with the ME score, you can see there's an overlap there. And actually, by the end of the program, the patients in that care home had higher levels of mood and engagement. And we saw a really big increase as well with the behavior category. We didn't get to see it overlap, but it got very close. So this type of data, we ran what's known as a difference in difference statistical analysis here. And we compared 2 differences over time, the differences in the trend before and after for the treatment group or for the group that received the intervention, and then comparing that against the control group. And we found statistically significant positive impacts on both of these indicators for this 30-week program of arts reminiscence. And we're able to conduct with that a cost effectiveness analysis. So we didn't value the outcomes here. We don't have a value for those ME and the BCC scores. But what we did was we looked at the changes in those scores, multiplied that by the number of participants to get an overall impact of the change in those scores from the program. So for mood engagement, it was close to 88-point change. The behavior category is about a 19-point change there. And we compared that back to the costs of running the Radical program. So this is a fairly typical standard CER calculation, the cost effectiveness ratio. It basically says that to improve mood and engagement by 1 point, the data tells us that it costs around £1,369 to do that. And that gives you a sense of the overall effectiveness. You could then compare that to other types of programs. So let's say a non, maybe a physical activity intervention with people with dementia. How does their mood engagement score impact it? How is it impacted? And what is the cost effectiveness ratio? And you could compare that against the arts program, for example. So that's just a really quick kind of tour of the type of work that we've done, but hopefully it gets you a bit of a sense of how these methods from the Green Book can be applied and used by different programs and different organisations.
It really does. Thank you so much, Daniel. That was really super interesting. And I think for all of us, those of us that are not economists and health economists, it really reveals the complexity of these sorts of analyses. And we know that that is a huge challenge and a barrier for many providers. So I think Marie's point of, do we all need to be evaluating the cost effectiveness and the value of our individual interventions and programs, or should we be thinking more about building this evidence base in a different way? I'm very conscious of time, and we've got some questions in the chat and in the Q&A, and I really want us to have a few minutes for our panelists to be able to address those questions. A huge thank you to all of our panelists. So if it's all right, I'm going to move us straight into the questions in Q&A and ask, I think the first two questions I'm going to move to are really directed at our first set of panelists in the first half of this morning, if that's all right. We've got two questions that are sort of interrelated. We've got a question from Jenny and also from Nick that are really about the definitions of medical versus non-medical intervention. Jenny's question around that is around where the arts therapies fit into that model. So I don't know who wants to pick up that. Whilst someone's volunteering to answer that question, I'll get you thinking about Nick's question, which is an extension of that. And Nick says, if we're looking at true integration of cultural approaches within health and wellbeing, is this a helpful model to work from, especially if we're considering a holistic approach to health and wellbeing, or is this the starting point from which to develop? So any of our panelists want to attempt to address that thorny issue of medical versus non-medical? I'm looking at Helen, but she's not volunteering at the minute. Anybody else?
Sorry, say that again.
This was a question, two questions about the definitions of medical versus non-medical interventions, and whether they're helpful categories, and also, for example, where things like art therapies fit in.
Yeah,
and I suppose it's that, yeah, the overlaps between those. Any thoughts on that?
Yeah, it's a really good question. And I think probably there's multiple ways you could cut it. But the way that we use as a kind of currency within Gloucestershire is, if you are talking about an intervention within a clinical pathway where the route to get into that is a prescription effectively from a clinician, then that is the non-medical intervention for a medical need. So you would need to have that diagnosed condition and you're being referred into it or given access to it because of your clinical need. So if you have complex pain and you're referred into our art programme for people with complex pain, then you have been diagnosed with complex pain and a clinician is giving you that referral. That doesn't mean somebody who independently feels pain couldn't access something, but that's how we would really describe that difference. Whereas you can have interventions that are about that broader health and well-being. So that could exist for somebody. So say we have somebody who's seeing their GP, but the GP independently felt they would benefit from social prescribing, but it doesn't relate to their clinical condition, then that's a non-medical intervention for a non-medical need. So it still could still come through a health contact, but it's about that broad health and well-being offer, as opposed to singing for breathing or support for complex pain or children with mental health needs, where you're expecting it. I guess another important thing, I'm sort of thinking this as I say it, but you're expecting a degree of expertise in the provision that is tailored to the person who has that medical need as well. So we would be providing support and training. So say, for example, the arts programme for Cinderford Art Space, we talked about Cinderford, the talker who's talking about some of the offers in Gloucestershire, which has been for children with diabetes. The practitioners, the arts practitioners who worked in that programme, worked with the clinicians, developed some expertise around supporting children, particularly to talk about diabetes, to support them around diabetes self-management, and actually became really confident and really skilled when those children maybe had exacerbation of their condition. Working with them, I heard they took a particular van when they were doing an event. There was a young person who had to be sort of laid down and supported because they had a bit of a hypo event, and the practitioners in that example are expecting to work with a group of children who are diabetic as opposed to, members of the general community. So I don't know if that's specific enough, but does that sort of give a feel.
Hopefully that, and I think that speaks to that point that we were talking about earlier about capturing those wider determinants of health, isn't it? And particularly non-clinical interventions can do that.
Yeah.
I'm going to suggest we've got time for one quick question. We've only got less than 5 minutes left, really, because I want to hand over to Alan to give us a little wrap up. But a question from Cam Donaldson, and he's got 2 questions. I'm not sure we'll get to both of those, Cam, so apologies. But Cam says, first, are we in danger here of over-sophistication? This is in relation to economic methods, cost, value, different methods that are used, regarding differences between CEA, CBA, etc. Would we rather make significant progress by encouraging or even ensuring assessment of net resource impacts on one side and impacts on health and wellbeing on the other in the context of any particular evaluative study? A really good question. Andy, Daniel, Marie, anybody want to try and pick that up?
I've got maybe a quick response. It might not be an entire answer to it. It is complicated, and there are lots of different methods that are seen as kind of best practice and that you can apply in this field. And I've had this conversation a huge number of times with museum directors and gallery directors and things like that, who just find it a little bit daunting in terms of how to apply all of this stuff. I think what I would say is kind of the arts, heritage, creative activity sector is in danger of being left behind by other policy sectors. So when we're talking about the distribution of public funding, if you look at places like defense, education, health, crime, they have got very sophisticated frameworks. Transport is another one, where they're now at the extent of kind of producing their own mini green books for those sectors. And within DCMS, there's been a huge push over the past 5 years. The Valuing Culture and Heritage Framework is one example, was one output of that, to really help speed up the level of progress within the arts and culture sector. Because without that, you're going to be left behind when you're talking to public bodies around funding and investment, if defence and education have far more sophisticated evaluation metrics that can demonstrate impact and value. And we've had that conversation here in Australia, here in the UK, but in Australia and New Zealand as well. It seems to be the same everywhere. So I would just say, kind of be concerned about the fact that you might get left behind in terms of public funding decisions if this isn't applied. So that's quite a monumental challenge, I think. But I think if you look at what the DCMS is doing, there's a huge amount of progress that's been made, and an attempt to provide to the sector some more standardized metrics that you can apply to make it easier in this type of work.
Thank you so much. And we're out of time, and that's a really helpful way to end that we know that these are ongoing discussions, and thank you very much for raising that the work that DCMS are doing, and we're also feeding into that some really interesting analogies with, I'm from the environment sector, and they've been through this as well, looking at ecosystem services. These are really interesting, very live discussions, so we'll keep engaging in those conversations. A huge thank you to all our speakers. I'm going to hand over to Alan Howarth to wrap up today's session, and thanks to all of you for participating.
Well, we are out of time, but thank you, Helen, for your brilliant sharing. Many, many thanks to all the contributors, panelists, and also to the audience for everything that's been in the chat and the questions. It has been a very rich and complex discussion, and I couldn't conceivably sum it up, least of all in half a minute. But I think there is a great deal of material here which will help our commissioners who will be formulating the findings of our Creative Health Review and putting forward recommendations to the government in London, but also to metropolitan mayors and other people responsible for policy in the regions of this country. What I think this has been particularly helpful in doing is enabling us better to define terms, to identify what the crucial issues are. The challenge is to demonstrate the cost effectiveness of creative health. And we've learned a lot about technical aspects of methodology, some of them pretty challenging and pretty difficult to address and get our heads around. Real complexity. And one of the questions that Andy's presentation raised for me was, who is actually going to be carrying out this work? Who's going to be funding these assessments, these evaluations, the application of these methodologies, whichever methodologies we alight upon? Who's going to be funding, who's going to be carrying out the work? And I think that's a key question for all of us to think about and for the review to try to answer. Victoria's presentation at the outset was fantastically helpful, not least in reminding us that cost is something that we shouldn't be seeking to minimize. There's a certain temptation, if you're trying to demonstrate cost benefit, to play down costs. But frankly, it won't do if the providers, the artists, can't scrape a living. And it's really shocking to see people in the workforce earning something like 15,000 a year. So, and it's shocking also to see that the NHS is only spending about half what the Arts Council of England is spending on creative health. And if policymakers will the ends, they must also will the means. So that lesson was hammered home by Victoria. Ellen and Tim both gave us the lesson that this is a long game. You've got to build up your data sets. You've got to build up your evidence very substantially over a long period of time so that you have a possibility then of converting what starts out as experiment and trial into something that I would hesitate to call orthodoxy, because orthodoxy always suggests that thinking has stopped, but something that is established in the array of resources that the system is willing to use. And it was very helpful and interesting to hear Kath and supported by Xanthi talking about the value of consortium working, and Helen again making this point about how if people can get the act together, they can be very much more effective and cost effective. But I thought what Helen had to tell us about outcomes in Dudley was extremely important, because what we're really talking about is what is it that makes strong communities, healthy communities, health-creating communities. And these factors are hard to measure. A point again underlined by Marie, who talked absolutely rightly about spiritual values, what it is that people in the end want: care, kindness, love, being heard, being understood, not to mention the wider issues of the social determinants. And there's a massive question about why it is that Whitehall can't get its act together collectively to address the social determinants, when so very obviously the key to improving health and making healthcare sustainable is to address the sources of ill health, which we failed to do. So these are just a few of the headline thoughts that I was left with. Daniel reported to us on research that he carried out. I'm sure it's ongoing, but some of the studies date back some considerable number of years. Genuinely helpful to some of our major cultural institutions, helpful to DCMS. But we have to ask ourselves the question, why is it that there is still no agreement across government as a whole as to how to measure what it is that you're seeking to achieve, let alone find ways to achieve it? You've all been incredibly helpful to us. There's a massive amount for us to digest, but thank you so much for these really valuable contributions to our thinking.